Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Brendan. How are you doing today?
Hi, Dennis. Good to talk to you. I'm doing fine.
Perfect. So the reason I asked you on, other than your background, today's topic is about zombie blood, or taking blood from people that have already recently expired or are about to, and then transfusing it into another patient that has a potential to live. So since this is the first time on the podcast, would you mind just doing a quick introduction of yourself?
Yeah, sure. So my name is Brendan Graham. I'm a physician, a doctor in the medical specialties of anatomic pathology and clinical pathology. I currently practice at a hospital on a U.S. Army base in North Carolina. And then what makes me somewhat, I guess, maybe more qualified than others to speak toward this topic is that as part of my training for anatomic and clinical pathology, I did a subspecialty fellowship that we call blood banking and transfusion medicine, which is everything blood banking and transfusion medicine. And I did that fellowship a number of years ago at the Mayo Clinic in Minnesota.
Perfect. And you're definitely the right guy to talk to about this. So maybe a year or so ago, I've started hearing kind of rumors and people's ideas coming up, and I think it's starting to build a little steam. So that's why I asked somebody like you to come on. With the war in Ukraine, blood supply is not, even here in the U.S., it's not super robust here. Put it into a third world country during wartime where there's lots of casualties that need blood. You can imagine it's even harder to get. So the idea was, hey, some of these people are going to die. Obviously, an extremist type situation. We've run out of blood. Now what are we going to do? This person's going to pass away anyway. We could take blood from him, give it to another trauma patient who has a better chance of living. Now, an actual thing that does happen, we take blood from chest tubes, we put it through a process and can reinfuse it back. It's not as good as fresh whole blood, but it's better than nothing. I guess, how do these, what happens to a patient when their blood, when they're in the dying process or have recently expired?
So, that's a really good question. And as everybody who's ever transfused banked blood knows, or has donated blood, we do a long process to ensure that individuals are in good health. And the reason that we spend so much time talking about your health and doing the testing before somebody donates blood is we have a saying in the blood banking world that we're absolutely insistent on the SQUIP, which stands for safety, quality, purity, and potency of the blood products that we collect and then bank and then transfuse to those individuals. So obviously there's a large process in ensuring that quality. I'll be very honest in my role as a physician and knowing what happens physiologically as someone is dying, for lack of a better word, that significantly changes the physiologic processes in the body. And one of my biggest issues with kind of what you had discussed before is I'm a big believer in the idea that I have strong beliefs that they're loosely held. I have no idea if this process would be better for dying patients than any other alternative, but I would posit that nobody else does either. And so in that situation where you don't know if it's going to be any better and you don't have any evidence in that sort of situation, we have to kind of use what we know about basic science and then try and predict in the future, while also being humble enough to say, like, hey, I don't know. And until we actually run that trial or run that experiment from that sort of standpoint, nobody will ever know. But what we do in the blood banking world is when we collect blood from individuals, they have to be at a certain hemoglobin and hematocrit so that when we transfuse blood, we know it's going to have adequate oxygen carrying capability. We make sure that individuals aren't taking any products that could affect their coagulation regarding their platelets or any of their clotting factors in their blood, because we know that if we're transfusing a unit like FFP or we're transfusing a platelet unit, those medications could affect it. What I would argue about people who are in the process of dying or in extremis, and when you're drawing blood of those individuals as they're dying or when they've recently died, I have to say that I'm almost positive that's going to be an inferior product. If that individual exsanguinated, their hemoglobin hematocrit is going to be 6, 4, something crazy on those sorts of levels right there. If you were going to collect that individual and then transfuse it into somebody else who's dying, there's going to be minimal benefit. In fact, you may be giving a lower hematocrit to somebody who's exsanguinating than they actually have in that situation and making their blood worse off. As an aside, when you talked about what we do in the OR, which we call red cell salvage, and we suck up that blood and then we transfuse it back into somebody, we actually hemoconcentrate that blood to artificially increase the hemoglobin and hematocrit before we transfuse it back into that individual. Because we know with the saline, everything else in the operative field, that if we were to just suck up that blood and then transfuse it back into somebody, we'd actually be exacerbating the problem by giving them a lower hematocrit in the transfused product than they may have on the operating room table. So one, I absolutely think the hemoglobin and hematocrit are going to be deranged in those dying patients, and we're going to give a product that's probably much less potent than what we would get from a normal donor. The other thing, and the thing that makes me much more concerned, is as the individual dies, there are some major physiologic things that go on beyond the decrease in hemoglobin and hematocrit in somebody who is exsanguinating. And the biggest thing that I'd be worried about is something that we call shock liver. And so shock liver is as the body is shutting down, as the blood pressure lowers, the liver is one of the first organs to be starved of blood as the body tries to maintain blood pressure to the other thoracic cavity organs, i.e. heart, lungs, and perfusion to the brain, which are obviously your holy trinity as far as the body is concerned for maintaining functions of life. And what shock liver does is it essentially puts you into ischemic liver failure. The liver starts failing because it doesn't have enough blood. Anybody who does any kind of medicine knows that essentially everything that's good in the blood outside of the red cells and everything that's bad in the blood outside the red cells is either produced by the liver or is filtered out by the liver in those individuals. And so what I see in individuals who are dying, and any intensive care physician knows this, is that shock liver causes some major derangements in the laboratory values of people as they're expiring. And the biggest ones that we can look at is certainly the liver enzymes go up. The bilirubin can go up sometimes 6 to 8 times normal in that sort of situation. LDH rises significantly because the liver isn't able to clear out that LDH that's being produced by the anaerobic metabolism inside the cells of the body. The other big thing is, as we know, the liver produces all of the coagulation proteins, both procoagulant and anticoagulant, to kind of keep coagulation in balance. The liver is clearly not producing those proteins as it fails. So what we see is the things that you can't really measure in blood without that complex laboratory equipment, those things get massively deranged in people who are dying. And the idea, and again, I don't know, but to be honest, nobody else does either. The idea that what we draw from those individuals is going to be a physiologically beneficial fluid, to me, is something that I doubt significantly. And this goes beyond the fact that, hey, it may not have no effect, but based on what we talked about with those physiologic derangements, if the individual had developed sepsis or any kind of bacteremia as they were dying in that sort of situation, by the way, we know that when people die, bacteria immediately starts to grow in the blood without the immune system. So if you're drawing it from people who are recently deceased, there's a significant possibility that you're going to be drawing clots up into the bag or bacteria that you're going to infuse into somebody who's significantly sick. Those physiologic derangements that we just talked about, they're going to make the blood less able to coagulate, less able to break up clots if the coagulation mechanism is too far on the clotting side from that sort of standpoint, full of LDH and all the other stress metabolites that somebody who is dying has too much of, and we may be transfusing more of into that individual. All of that just makes me look at it and say that if I were a betting man, I would bet that this type of blood has either no effect Or what makes me worry significantly more is it would have a significant detrimental effect on that individual. And instead of giving essentially saline that's going to do nothing, you're possibly causing harm. And the only way that we would know that is that giant randomized controlled trial where we say, hey, what are the outcomes? We change one thing in the care of these individuals, and what does this randomized controlled trial say? For other reasons, I'm sure we'll go into the future. That you can probably never run that randomized controlled trial, but that would be the thing where I say, hey, strong beliefs loosely held. If you can give me evidence the other way, then certainly I would change my mind. But from what I know about physiology, I would find that hard to believe. Along those same lines, we talked about in surgery when you do that auto salvage of blood. So, and I'm very familiar with this process. We used to do it all the time in fellowship. When we take that blood into the machine and people see it go into the machine, what they don't realize is that machine is washed with saline about 50 different times as we centrifuge the blood around. And the reason that we wash it with saline is because any metabolic factors in the blood of that patient whose surgery that could back in that sort of situation, the hematocrit can be back in that situation. And again, when we talk about drawing blood from the people in the process of dying or the recently deceased, none of those things that we do specifically to make a more pure, potent, safe product are going to be done in the field. And we know the reason that we do them in the hospital is because we don't want to harm individuals. I think we have to assume that some of those things that we're trying to remove from these products in a controlled environment are going to be infused into the individual that we're trying to help and have those detrimental effects that we would speculate about. Yeah.
Yeah. So, I mean, just from what we just talked about, we know like saline would just makes numbers better. Well, yeah. Like blood pressure numbers look better. You're not actually helping anybody. And it's almost a joke now if you see somebody, giving LR or saline, you would point your finger and laugh at them.
Yeah.
This sounds even worse than that.
I would say that again, like, and we'll be honest, right? Like, we didn't know any better and we were so afraid of the infectious disease things in the past. I think we look at saline now and we say like, hey, we sustain blood pressure. Now that's important, but that's 10% of what we're trying to achieve in those individuals, right? And now we look at it and say like, hey, not only do we have to sustain blood pressure, but we have to have oxygen carrying capacity. And that was the idea of, okay, red cells and saline. And that was certainly better than the other one. But then we said like, okay, we're not doing anything about coagulation and the coagulopathy of trauma. It has to be red cells and then some form of plasma proteins and preferably platelets so that we can try and recapitulate this. I would say in the situation that you're talking about, whereas saline probably maybe gave you a 10% of benefit and didn't hurt somebody. Yeah, I would say that the product that we're talking about is, maybe at best that 10%. It's obviously volume, so it's going to maintain for a short period of time that mean arterial pressure. But what makes it significantly different from saline is I think it has the significant chance to not just be a benign actor. Hey, salt water is salt water. It's not doing anything, but it's not going to kill you. This stuff, I think, has this significant ability to harm individuals.
Okay. So, I mean, all of this is, everybody's looking for like the holy grail of fluids for trauma patients, has all the good stuff, none of the bad stuff, no risk of reactions or anything like that. That would be the perfect thing. So far, the best we have is blood. We had mentioned before the podcast started, there's HBOX. It was like a bovine type hemoglobin fluid. We also talked about a little bit about hydrocarbons. Looking forward, have any of those shown to be any help at all?
Yeah. So what you bring up is like the future of blood transfusion in the Western world and over the world. And I think it's a really, really interesting kind of area. And it's got a lot of things that are going on. I think you're absolutely right. 10,000 years of evolution have designed a pretty good fluid to carry oxygen, to clot when things go wrong, and do all that sort of stuff. And so, yes, the hubris of man has, created these ideas that we can create these engineered things. They're going to be better than 10,000 years of evolution in Mother Nature, and nothing has shown to be as effective as banked human blood. What I would say is the major area of research right now is to, and obviously the big limiting factor for banked human blood is you need humans to incubate it, right? And if there aren't humans who incubate it, and there aren't humans who agree to donate it in that sort of situation, well, then you just don't have this great fluid that's obviously the primary sustaining fluid that you'd have in somebody who's exsanguinating. And so what the medical community is really working on now, and this is more of something that's being researched in Asia, specifically Japan, is, hey, we know that human blood is the best. Our biggest issue is, because humans are autonomous beings, we can't just like grow a race of people like, H.G. Wells' Time Machine and then tap them for blood in that situation and then use it all over the world. But we could harvest stem cells, put stem cells in bioreactors, and create human blood from human stem cells that we could actually make universally transfusible. Every single unit O negative without any of the antibodies that would make it incompatible in those sort of situations. I think that is absolutely on the horizon. The limiting factor right now is it costs about $25,000 in research time and materials to create one of those units. So right now it's just non-economical. In the future, as Moore's law brings the cost of things down, I absolutely think we will continue to transfuse human blood, but I think a large part of it won't be blood that was made inside of your and my bone marrow. It will be blood that was made in bioreactors, much like a lot of biotechnological processes are done right now. That obviously doesn't help us in the short term or the intermediate term, but I think that is the long-term future. To your point, what we did do in the past is we looked for other fluids that could maybe recapitulate some of the major factors of blood and see if they could be at least equivalent or maybe close enough to equivalent to human blood that they might be an acceptable substitute in those situations. And as you and I, anybody who works in this field knows, blood really has three major functions. One, it's got to carry the nutrients around the body and then provide that kind of highway system, for lack of a better word, for glucose, oxygen, everything else to get around the body. Two, those red cells have to carry that oxygen to support aerobic respiration and all those processes throughout the body. And then three, the other major product of blood, or the other major function of blood that we worry about in this situation, which is trauma care, is that ability to clot and not get so deranged that it actually interferes with the clotting process and then makes things worse. And so we know of no product that single-handedly will do all of those sorts of things. But as anybody in I think your and my community knows, there are things that we've done to try and approach parts of those functions. And so the big thing that I would look at and that you mentioned is, one, hemoglobin-based oxygen carriers or other carriers that are meant to carry oxygen and deliver it to the tissue and maintain that cellular respiration. And that was an area of active interest about 20 years ago. I would say that, and we can see that, hey, that's great for carrying oxygen, but that does nothing for coagulation. And then I think I would look on the other end and say something much more recent in the last 10 years. Well, hey, what about lyophilized plasma? So we're not creating one single fluid that might be able to do everything, but possibly you're able to create a number of different things that science has created that we know, like, hey, no, none of them are equivalent or absolutely as good. But if you're part of the any port in the storm, this is extremis, maybe by combining them, you create some facsimile that does just enough to sustain life until you get the next echelon of care or whatever you're doing. So specifically with HBOX, about 20 years ago, the Navy Special Forces community was very much interested, and DARPA funded a lot of the experiments that were going on. In my fellowship, I was at an institution that worked on these products. But what they are is they're HBOX, or hemoglobin-based oxygen carriers. And what they've done is they've taken a slightly modified form of bovine hemoglobin, or cow hemoglobin, the hemoglobin or the protein that carries oxygen. And they take that from the cow, they link 4 of those cow hemoglobin proteins together, and it turns out that cow hemoglobin, or that bovine hemoglobin, can carry human oxygen. And then we we suspend it in an isotonic fluid, and then we would transfuse it into individuals. And it turns out that, hey, these hemoglobin molecules can carry oxygen and deliver it to human tissue. So we did a number of studies on the HBOX in the early 2000s at major trauma centers around the country. And long story short, it was acceptable. It didn't cause significant amounts of harm. It didn't. It did have a little bit of a salubrious effect. It did have benefit for the patients. We saw slightly better outcomes than just giving saline in those sort of situations. But the FDA rejected all of those products for standard clinical use because we clearly showed that they were far inferior to banked human blood in those sort of situations. Obviously, we're not talking about, hey, banked human blood versus HBOX, because you obviously don't have the option of grabbing that one off the shelf. But if banked human blood or even a walking blood bank isn't available, because HBOC can be created and stored, is a lot more stable as far as temperature goes, that might be a solution that you look at in those sort of situations to deal, obviously, with the oxygen carrying component of people who are exsanguinating. And then I would argue that possibly in the right titration, if you use lyophilized plasma, you're getting to a situation where, hey, am I creating a good enough fluid with these hemoglobin-based oxygen carriers and then reconstituted lyophilized plasma to be able to possibly sustain both oxygen delivery and coagulation for this short period of time in our last ditch effort to be able to keep somebody alive until we can get them to the next echelon of care, or some other supplies are going to become available that allow us to treat that individual more optimally. So those are what I would look at. The HBOX, like I said, we found that they did a pretty good job of delivering oxygen. They just weren't nearly as effective as banked human blood, which is why the FDA approved it. You did mention another one, which are some hydrocarbon, actually fluorine-based fluids that were developed in the late 90s and early 2000s. And the goal is that the oxygen dissolves much more easily in these fluids. And so we weren't going to give a hemoglobin-based oxygen carrier. We're going to create this fluid that had a higher partial pressure of oxygen in them. And then we were going to actually inject this, and they were experimenting this in cardiac surgery. Hey, there's a blockage in the heart. Can we get this little catheter beyond the blockage? Can we release this fluid with a higher concentration of oxygen and maybe keep the heart alive for a little bit longer and not have all those side effects that can come with heart disease or a myocardial infarction? And this kind of speaks to what we talked about before. Strong beliefs loosely held sounds like a great idea. We tried the randomized controlled trials, even though we engineered this thing with the best of intentions and all that science could bring to bear on this problem in the initial instance. What we found is that, hey, we didn't anticipate that the human immune system was going to react to this fluid differently than it reacted to other things. And there was going to be a problem with inflammation in the heart that was caused by this fluid. And much more significantly, because the partial pressure of oxygen was so different and the fluid dynamics of this hydrocarbon fluid were different, we found that as this fluid went through the heart and migrated to the brain, the oxygen actually not precipitated, but diffused out of the fluid into the brain and created small air bubbles in the microvasculature of the brain and actually created strokes in these individuals. And so we look at it and we go and say, like, hey, I don't know, you don't know either. What we have to do is we have to experiment based on this. And based on what we would have hypothesized, we would have never thought this had been the case. But you clearly do the studies and you say, like, hey, the people who get this fluid that's supposed to help them do better after a heart attack clearly do worse than these individuals who did not get any therapy whatsoever. I think it's a human issue, and it's something that I have a hard time dealing with the military in general. But I'm a big believer in the idea of the action bias, and that the military inculcates this idea of an action bias, and it's true. An action bias is very helpful sometimes, but I think that action bias is paradoxically also one of the things that harms us the most, because we always want to be doing something, and sometimes when we do something, and we all know this from our own personal lives, it makes things worse. And so my significant belief and my biggest concern, without any evidence behind it, is that people who would do this in the same way that we ran those experiments in the 90s with the fluorine hydrocarbon-based carriers, that we would do this and then find out after we finally looked retrospectively at the evidence, hey, these people did worse. And it honestly may have been better to use saline, to use hemoglobin-based oxygen carriers, or maybe even use some other kind of fluid in that sort of situation to try and sustain those individuals. And again, we just don't know. And I'm certainly open to changing my mind about the science and the physiology, which is just one aspect of the issue that you brought up. But without that clear randomized controlled evidence that proves to me in vivo that this results in better outcomes in the appropriately controlled trial, I would have to rely on what I know about human physiology and what's happening in those situations, and hypothesize that this is not even going to be a neutral product, but I would bet a harmful product.
Yeah. And like you mentioned, action bias. I mean, you can't, and it makes complete sense why an idea like this would come up in our community, is because we're selected to be driven, and we have a firm belief that we do not lose, and we just keep going, and we do absolutely everything, even to an extreme, in order to win.
Yeah.
And so the thought of losing is almost, it doesn't even come up. So we just keep going and going and going, and not necessarily understanding you actually could be doing the opposite of good. Which leads to kind of the moral, ethical question of this entire process. I'm going to take blood from somebody who is in the dying process. We've already triaged them, like, I can't save this person, but potentially I could save this other guy if I was able to take his blood and give it to him. And, just looking at the surface, that makes some sense. Take red stuff out of this guy, put him in that guy. Maybe we save the day. But I mean, oh my God, like you're essentially exsanguinating a person faster. So that has got to be the opposite of palliative care. And not to mention, like, just the moral damage I would imagine somebody would have, if you have a soul, of saying, I'm going to not only triage you that you're going to die, I'm going to take your blood faster, hopefully for good. But if you're infusing inferior stuff that at best does nothing, at worst makes the patient even worse, what are we doing?
Yeah. I mean, I think you hit the nail on the head. And obviously this is, the nice thing about science is in most instances, it's not really relativistic. We can point to the numbers, and here we're getting a little bit more into the nebulous part. And obviously it significantly relies upon your belief structure and your belief system. We're both Americans. Obviously we benefit significantly from the development of Western civilization and the morals and the foundations of Western civilization. And heck, as Americans, there was a very specific belief about the rights of the individual versus the rights of the community, and why we created a nation to try and walk a middle way between those rights, but to ensure that people are able to pursue what they want out of their life, and everybody's not just a cog in a machine from that sort of standpoint. So, I mean, at the risk of sounding too relativistic, I think, you and I believe what we believe, and we live in the United States of America because we believe it's right, and that these should be a basis of human life and of human autonomy. But I certainly understand that and recognize that people may not feel the same way. And while I would argue that they're objectively wrong, there's no way on this plane that you and I are going to be able to prove that. So with that said, and acknowledging that people may have different belief structures, I mean, I think if you do believe in the Western idea of human autonomy and what a lot of modern representative democracies are founded upon, the idea of inalienable rights that come in documents that can't be taken away in that situation. Gosh, we've got a lot of problems with what you're talking about. We make people consent for organ donation. We allow people to withdraw, to remove consent at the last minute before they expire to ensure that we don't, violate their bodies in that sort of situation. When I do autopsies, and I'm obviously working on the remains of the deceased to try and gain more scientific information, I absolutely don't do that without either the assent of the next of kin, or a medical legal reason where the state says, hey, I have to know if this individual was murdered or if this is a suicide, and then the state allows me to perform those studies on the remains. So I think we've got a major problem that even if you could say that somebody consented to organ donation, I don't think we're going to be able to get consent in these sort of situations for these individuals. And then you get into the idea that this this may bias you. And I think one of the biggest issues that I saw in the world over the past 20 years as a physician was the scandal in China, maybe 10 or 20 years ago, where we found out that the individuals who were executed by the state in China for criminal reasons, their organs were harvested. And there was no consent that went along with that in that sort of situation. For a while, China was doing more organ transplantations than any 4 or 5 countries combined in the rest of the world. And a lot of these organs came from criminals who you would argue and say, like, hey, that's an ethically dubious thing to have the state exercise the power of life or death over somebody in that situation, and then also have the ability to harvest organs. Oh, and by the way, there were questions about whether wealthy individuals from other countries were actually flying to China because they had an availability of organs in those sort of situations. So I think it's a massively ethically perilous situation that you would get yourself into, where you may be biased in a certain way because you're trying to do the right thing. And I think, as you mentioned before, and one of the sayings that I'm very fond of is that the road to hell is paved with good intentions, right? And we know this from the history of warfare and the history of the military. I don't think most people are broken, ethically terrible, bad, sadistic people. But when we look at the things that we say, like, hey, that was wrong, how did we get to that point? None of us see the 20 or 30 ethically compromising situations the individual was in beforehand that progressively moved the line of what was acceptable to the point where they're doing this sort of thing where the rest of the world says, like, hey, that's completely wrong. And you're looking at yourself and you don't even recognize who you are because you would have never thought that you were capable of doing this sort of thing. And I do worry, as you kind of alluded to, that we're getting to a situation where we believe the ends justify the means. And so we do these ethically problematic sorts of things because we believe we're doing the right things, let alone what we just discussed previously, that we may not be helping the individual. We're probably at the best doing something that's neutral and with a significant risk, I think, of harming those individuals. But in those situations, you're so focused on the end that the means don't make their way into the mental calculation or the moral calculation. And then, gosh, before you can even recognize it, it's, 2 or 3 years down the road, you've made multiple decisions in the same vein. And then you're doing something that makes you disgusted with yourself because you never thought you'd be the kind of person who would do those sorts of things. And so, yeah, I do definitely worry that this is one of those things that just becomes one of those cobblestones in that path to looking at yourself and saying, wow, I didn't think I would be this person. How did I get here? And you would know better than I would. So I would certainly defer to you. And I'd love for you to take me through how these things develop in a deployed or a very difficult situation like that, where the goal line moves incrementally further without people recognizing it. Because I think we can both acknowledge it's in the pursuit of something good, but gosh, you got to be careful about how you get there.
Yeah. I mean, just from my uneducated point of view, it begins when you're selected. You're selected because you win. You're selected because you're first. You're selected because you're the strongest, the fastest, the smartest, the whatever. I happen to sneak in under the bar. But it begins there. And the idea of winning, achieving success, completing the mission, that becomes like just the mantra and the mindset. And irrespective of what the problem is, whether it's a tactical problem or what we're talking about, a medical problem, the mindset is still there. I win. This is why the whole palliative care discussion is actually a discussion, because at no point in time did anybody ever say, this person is too hard to fix.
Yeah.
Our training scenarios, the guy has a TBI, a tension pneumothorax. He's already exsanguinated 4 units of blood. He has a compromised airway. You have 10 minutes to fix this person. Go. And that's the training, And so you're used to just do. Okay, did I accomplish all the tasks in the right amount of time? Yeah, yep, you did. You win. All right. It fits in line with all my other successes. That's the right thing to do. So at no point in time did anybody ever say, like, hey, this guy was just too hard to fix. He was just too sick. That's why it's not your fault. It's just what happens. This is what happens when people are injured. This is happens in war. So you, especially, I would imagine medics, but I imagine any medical provider, when faced with death, it doesn't jive. And that's where the moral injury comes in. That's where the psychological issues come in, is what happened doesn't match with what my expectations of myself or the situation would be. Obviously, I'm wrong. And that doesn't compute in the community.
That's an interesting thought. I would say that that probably makes it harder from your perspective. And obviously, I'm not a trauma surgeon, but my wife, who's also a physician, and I, we would look at it and say that, yes, it's in part our job to fix individuals, but also knowing that death is an inescapable reality. What we view as a huge part of our jobs as physicians is ensuring that people have a good death, and that the death is on their terms, and it's what we and they would consider to be a good death. I certainly acknowledge that I don't, the moral things aside and the philosophical things aside, somebody who's dying traumatically in war, where it may be good on the grand scheme of things because you're trying to achieve national and moral objectives from that sort of standpoint, I don't think anybody would call that individual a good individual death, a good death, even though it may be a heroic death and it may be good for society as a whole. So I think that your point there does make it very difficult, and I think probably reinforce the action bias as to why you might do these ethically dubious things in pursuit of this idea that, like you said, we always win. There's nothing that's insurmountable. Although, Ben Franklin would have told us that death and taxes are
right. And
are
it's
insurmountable.
It's not,
so just get used to it. Yeah.
And it's not like we don't actually know that at some point everyone dies. Like, yeah, we know that, but not on my watch.
Yeah.
And I think, and the whole point of this podcast was not to just crush anybody who had the idea.
No,
I love all ideas, and which I think they should all be discussed to whatever depth they need to be discussed. But like you mentioned, it's the cog in the gear. It's the next cobblestone that just pushes us potentially in a wrong direction, because we don't know. We don't know enough, and maybe we don't ask enough questions to the right people or the people who have more knowledge. What do I actually get if I were to draw a unit of blood from somebody who is in the dying process? What does that even look like? Red stuff does not equal red stuff. Yeah. Things change. You have a living tissue in the dying process. It's not the same.
I think that's the biggest takeaway, is that the physiologic processes in death, they are extreme. And the idea that the blood that you would take out of somebody who's in the process of dying, who has shock liver, who maybe has sepsis, who's already lost, half of the blood volume, and the hematocrit is, 4, and the concentration of fibrinogen is like, 87 or something like that. In that situation, you are not giving somebody the equivalent of a banked unit of blood. And with all the things that we discussed, it's possibly harmful. And I would suggest that it probably is harmful, with the best situation being neutral. And then we go back to what we talked about before, is that I don't begrudge anybody anyway. I think a lot of times the reason that we latch onto an idea is because we don't know if there's a different alternative, and I think that's what you and I are trying to provide in that situation. I'm a big fan of the great Carthaginian general Hannibal, who in Latin, viam in veniam aut faciam, I will either find a way or I will make one. And I think there's always a better solution. And we certainly understand what people who would do this in this situation are driving toward and what they're trying to achieve. And then the question is there a better way? And I think that you and I would suggest in that situation that, like, hey, there are some scientific products that were created in an attempt to try and replace human banked blood. They clearly weren't equivalent when we compared them to the standard of care. But hey, you and I aren't talking about the standard of care in a controlled environment. We're talking about any port in a storm, and these may fit the bill in that instance. So the major one, if people want to look into it, is a product called Hemopure, which tried to be approved here in the U.S. by the FDA and was used in a number of trauma centers. And I personally, you and I mentioned it. It's not approved by the FDA for clinical use, but there have been unique clinical situations where myself and other physicians have gone and applied for what's called the compassionate use exception, where we tell the FDA, hey, we're not using this in a basic clinical scenario. This is a very specialized clinical scenario where we think this is the best chance to compassionately use this product to save somebody's life. And we've seen it achieve the ends that we desired in those situations and allowed us to extend life to get to a point where somebody could recover or we could use the next therapy in those instances. And so I think that's definitely something to look at since it's not manufactured in our own personal bioreactors. Like certainly the companies that make this have an economic incentive to produce tons of it. And so I would think it'd be available in much greater quantities and volumes than the bank blood that we're talking about before. It was designed to not have to match with the antigen structure. So blood types, O, B, AB, doesn't matter in those sort of situations. And I think that might be something in these situations that people will be looking at. And then as we discussed before, that's just the oxygen carrying capacity. As we know, in the last 10 years, we've had a much better understanding of the coagulopathy of trauma and what the non-red part of blood brings to the equation and what it does in those sort of situations. And I think one of the biggest advances, and you certainly correct me if I'm wrong, that the SF community seems to use significantly is the lyophilized plasma and the ability to take human plasma, freeze dry it, have it be temperature stable, take it into the most austere environments, and then simply reconstitute it with warm saline and create essentially a facsimile of liquid plasma that can hopefully bring some of those coagulation factors to the game and sustain life long enough to make it to the next echelon of care.
Yeah, awesome. Well, thank you again, Brendan. I really appreciate you coming on.
Appreciate it, Dennis. I was glad to help.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.